I'm pleased to be here. I'm a psychiatrist. I'm not OBGYN. I don't work with your population. I work with a similar population. I work with people who generally come from lower socioeconomic groups who have terrible, terrible consequences of their lifestyle decisions, who don't seem to be able to take care of themselves in any way that we, at least in healthcare, would like them to, who have terrible habits that they can't break, that are very difficult to communicate with because they don't trust me. Does that sound familiar? And so I do have that experience, and that's what I want to talk with you today. But I do have a perspective from mental health and from psychiatry that I just wanted to share for a second. And that is how important the work you do is. I work a lot with kids, and I work with adults, and I work with people who have just ended up with terrible mental illnesses and awful obstacles in their life. And I know from all of the research how poorly our kids are doing today. There's a great paradox here, because if you are a middle class or upper middle class kid and you're bright and you've got an intact family, the sky is the limit for you. When I look at when I was in school, this gives me an opportunity to say that, because none of my kids, none of the grandkids will hear it from me. But when I was in school, we had like nothing. I went to a rural school in a small town called Norton, Ohio. We didn't have any interesting classes. My world history class was, we passed the book around from student to student and read the book out loud for a year, because our teacher was the coach of the football team and the basketball team, and he didn't really want to do any teaching, so we just passed the book around. This was the sort of stuff that I had for education, at least in high school, and it wasn't until you finally broke away and got to college, if anyone suggested that you could go to college, that you started to get some education. Kids today have so much, even just at home, on the internet, all of these learning modules, all of the opportunities in school from junior high on. I look at what my granddaughter does, and it's just really amazing. So for some kids, this is the golden age for learning. I mean, if you can't get excited about learning, there's something wrong with you at this point, I think, because there's so many opportunities. But that's just for some. And then there's this other group, and this is the group that's doing worse and worse and worse. They are not engaging with school. They are not finding any sort of interesting occupation. They are not getting married. They are not finding long-term romantic or family-based relationships. They are angry, they are addicted, and they are doing terrible. And if you look at how the United States is doing compared with other countries in the world, our kids are not doing well. And whenever I say that to a group, they say, yeah, but my kids are doing well. Yeah, that's because you're in this group. It's that other group. But I think it has to do so much, not with whether or not there's a Head Start program in school, or whether we do diversion for juvenile crime and that kind of thing. I think it has to do with healthy pregnancies and whether there's some sort of home that you come into. We are only beginning to understand the effect of biology on the developing nervous system and the long-term effects of that. Genetics, the in utero environment, the mental state of the mother, all of these things are entwining in ways that we are starting to get a physiological explanation for through epigenetics. You have heard of epigenetics. It's the influence on our genes. Your genes are turning on and off all the time, thousands of times a minute. Do you need more epinephrine? Do you need more hydrochloric acid for your stomach? Are you getting hungry? Do you want to eat? What else is going on? Your body's making these things all the time or turning it off all the time. And our genes are turning on and off depending on what's going on in the environment around us, your internal environment, me speaking, what's going on in your head, what happened to you this morning. All that kind of thing is turning genes on and off. Well, it isn't just genes related to your bodily functions, it's genes related to your mental functions as well. And so we know that early abuse, early neglect, early chaos turns genes on related to stress, reactions to stress, and sensitizes the person to stress in ways that we think may last a lifetime. So what is a major risk factor for whether you develop PTSD in the military? It's what happened to you when you were a kid. Do you have a previous mental illness? Do you have previous trauma? These things set the stage for what we deal with for the rest of our life. Now, this isn't new. We all know that from our own lives, right? Things happened to me early on, and I kind of remember those, and I have tendencies toward certain sorts of behavior that I think are in part determined by that. But for these kids who don't do well, who are unable to adapt, who don't learn very well in school, it's a lot of this stuff, I think, that happens very early on, including during pregnancy. And that's what you do. And I think this is the most crucial work that we have if we want to have healthy generations who are able to think instead of react emotionally, who are able to produce and contribute. So this is it, as far as I'm concerned. So anyway, I'm very glad to be here. If you have any comments or questions about what I talk about today, please feel free to email me. My email is on your handouts. The handouts have all of the information slides that I'm going to put up here, so you shouldn't need to write down anything. It's all there for you to read for fun or share with the family around dinner tonight. What did you do today? Oh, I did this. And here, let's go over some of the slides together. That kind of thing. So what else? All right. So anyway, the importance of what you do and working with people who are pregnant. And this is you. You're greeting one of your clients, and you're going to tell them, I've got all these things that you should know. And when I tell you these things, you're going to change your behavior, right? So first of all, there's nicotine. If you smoke during pregnancy, here's some of the things that we know. We know that nicotine has greater harm for developing fetus than even opioid abuse. We know that 1 in 6 of you smoke. We know it crosses the placenta and breast milk with levels of cyanide and carbon monoxide that are 15 times the level that people have who are not exposed to smoke. We know that you have increased risk of miscarriage, decreased weight gain, chance of sudden infant death syndrome, decrease in IQ in the children, also increased impulsivity, concentration, language development problems, learning difficulties, maybe due to problems with auditory function related to the nicotine exposure. And the newborn will show nicotine withdrawal over 48 hours. And then you'll say to them, here's what alcohol does. 9% of pregnant women report current alcohol use, and 2.7% report binge drinking. 2 to 5% of school children show fetal alcohol spectrum disorders. There's a whole spectrum here, not just the disorder. And even in the absence of fetal alcohol syndrome, intelligence scores tend to be lower in children exposed to moderate heavy drinking during pregnancy. We also see learning deficits, poor executive function, impulsive behavior, aggression, inattention, and poor social interaction. And then, of course, there's fetal alcohol syndrome, and you'll tell them all about that. And you're going to hear about that this afternoon, but here's some of the things that you can talk about. These are all problems that happen that we cannot predict. If you're drinking during pregnancy, you may have a child that shows this. What about marijuana exposure? This is the most commonly abused illicit drug during pregnancy. We see low birth weight, higher incidence of psychiatric disorders. It appears that the marijuana interacts with a very finely tuned neurologic system related to this endocannabinoids that regulate brain development during the prenatal period. Exactly the time when you need that brain to be developing, you're screwing it up by exposing it to cannabinoids. Developmental problems may occur as late as 3 years old. We don't know. And you would end up saying, we don't know what a lot of the long-term behavioral effects of these habits are. but we can't imagine that they're good. Why take a chance? And then they turn to you and say, you're right. I'm stopping all of my smoking. I'm not going to drink anymore. No more smoking dope for me. In fact, I'm going to take my prenatal vitamins. I'm going to start an exercise program, and I'm going to change my life. And you're done. And that's all I have to say, because I can't imagine anybody telling me that. What else would you need to tell me to make me to stop smoking or not drink during pregnancy or change my behavior? What else would I need to know? Well, for me, not much, but for other people, a lot. And that takes us to the question, what is it that makes people change? Why do people change? And this is the $100 million question in mental health. And I'm sure it is in any of the other health professions as well. Why do people change? I have a couple interesting stories. Well, I don't know if they're interesting. I guess you decide that. I think I'm interesting all the time. But of course I'm not to everybody. When I started going to the dentist as an adult, my dentist always told me, you need to floss. You need to floss. And I didn't floss. Why should I floss? And I go to the dentist and they say, you need to floss, and I would ignore them. I just ignore the dentist. One day, this was probably 20 years ago, I went to a dentist and the dental hygienist said, you should floss. Here's some flossing things, as I was leaving the appointment. And I thought, she's right, I should floss. And I started flossing my teeth, and I don't think I've missed a day since then. What was that about? What happened? Why, after years and years of not hearing this, or at least thinking it didn't apply to me, or thinking I don't want to, or I can't, or what a bother, all of a sudden, I heard it and I changed. Have you ever had that experience? My father-in-law smoked cigarettes. He started during World War II when they handed out cigarettes for free to all the GIs, and he smoked unfiltered Camels. And he smoked a ton during his adult life. He was a farmer in Kansas. And one day he was driving down the road and he got out a cigarette to smoke it, and he looked at it and said, I'm not going to do this anymore. And he threw the pack out the window. Now I know we don't like that because it's littering, but we do feel good because he stopped smoking. He stopped smoking and he never smoked again for the rest of his life. What is that? How do we account for that? How do we account for people who just stopped drinking one day, who've been an alcoholic? We don't have a biological model that this fits. If I were going to talk to you about alcoholism or other sorts of addictions, I would show you movies of what's going on in the brain, of how different learning centers are changing during, addiction and the addiction behavior, where it becomes less impulsive and more compulsive. And I have all these words for it that would show you that when you become addicted, you lose control of your behavior. But in the back of my mind, I would be thinking about, how come my father-in-law could just throw his cigarettes out the window and not smoke anymore? How come these stories of people stopping drinking? Why did I start flossing my teeth? And it all comes down to this: what makes people change? We don't know what makes people change. We try different things. Motivational interviewing, have you all gotten around to hearing about that yet? If you haven't, I'm sure you're going to get that for the next conference. Motivational interviewing seems like a good idea. Why not give it a try? Psychotherapy, we can try to scare people. We know that doesn't work. Don't bother with that. The research is, about scaring people about smoking. The more you scare them, the more they smoke. We think it's related to their anxiety, because their anxiety goes up and they start, oh my God, and I'm going to die from smoking. I can have a cigarette. There's this disconnect that goes on. So in any case, what makes people change is a big one. This is a picture of an old computer, and it's running a program called ELIZA. ELIZA was the very first computer therapist. It was devised in 1964 to emulate a Rogerian psychotherapist. You're all too young to have heard of Carl Rogers anywhere along the way. Carl Rogers was a big deal back in the 60s for people who were interested in mental health. He developed a style of listening which is basically reflecting what somebody said. He didn't really offer advice. He didn't say anything. He just sort of, people parodied this a lot. It worked for him. It didn't necessarily work for everyone else. But that's what Eliza did. Eliza had almost no intelligence whatsoever, only tricks and canned responses. But when the original Eliza first appeared in the 60s, some people mistook her. And notice, even in the article, they talk about her as though this is a person, as a real human being. Here's a site where it is, and I'm going to pull this up. And we're going to do, if this works, which I've got no reason to believe it will, but it might. We are online, and this is Talk to Eliza. So this is Eliza now, and she starts and says, hello, I'm Eliza, and then I'm going to say, hello, I'm David. And then I put that in. And then Eliza says, do you believe it is normal to be David? I didn't know this was going to come up. And so I'm going to say, I'm not sure. And then Eliza says, did you come to me because you're not sure? And then I'm going to say, no, I came to you because I have low energy. And then Eliza says, we were discussing you, not me. Now, presumably, they've taken some of the bugs out of this, and it can do better now. But you get the idea. Here's a computer, no cognitive understanding of what we're saying, but it's just responding to words. I can't help if you will not chat with me. I'm getting angry. And then Eliza says, do you enjoy getting angry? Okay, we're done, Eliza. I'm walking out. So that was Eliza back in 1964, and Eliza was the first computer therapist. Here's another exchange that was online. Hello, I'm Ellen. I'm afraid. How long have you been afraid since midterms? Tell me more. I'm afraid that I'll fail my course. Do you enjoy being afraid that you will fail your course? Things didn't stay there. This is Kismet. I don't know if you can see this or not. Kismet was the first robot that was designed to display human-type features. So Kismet could raise eyebrows, smile, frown, move his or her ears. It was developed in the late 1990s by Cynthia Breazeal at MIT. This is considered the world's first social robot. It was a robotic head. It simulated emotion through facial expressions and movement. This is Parle. Parle was designed as a social robot specifically for elderly and for people who were in nursing homes, who were lonely. It's a therapeutic robot intended to have a calming effect on patients in hospitals and nursing homes, primarily people, I think, with dementia was a group that they were working with. It was designed by a Japanese system and was first exhibited to the public in 2001. It was in the shape of a baby seal. This is NeckSee. NeckSee is a robot also from MIT, but one of its roles in 2013 was for a social experiment at Northwestern, and the experiment was whether they found that humans were better judges of trustworthiness after they see visible body language signs of dishonesty, and robots were regarded as more trustworthy if they showed the right kind of gestures. So it was designed to try to figure out what is it that will make you trust it. And so they would practice developing those things to make it seem trustworthy to people. This is Parle. Parle is a robot that's designed to interact with children. It's a very curious robot, and what they found was, with Parle, that if children interact with Parle and Parle is curious about things, children become more curious about things. So children will start to imitate the behavior of the robot. This is Zeno. Zeno is a robot that's designed to help children with autism become more interactive with something in the world that is closer to animate. Zeno helps engage children with autism. It's a collaboration of private sector and University of Texas. Children with autism are often less threatened by robots than people. Finally, this is Romibo. Romibo is, you can buy this, and you take it home and you can program it, and it can take care of your kids for you. I shouldn't have said it that way. But it's basically a do-it-yourself robot kit. It's low cost, open source, and the toy robot features social aspects that are effective in provoking emotional response, making it an ideal candidate for therapy applications, about $900. I looked it up online. So presumably if you have a child with anger issues or other sorts of issues, you could get this robot who could actually be therapeutic and help interact with that. It's controlled with an iPad. It connects to the internet. It downloads information and can share stories. Finally, I guess I said finally before, but this is the latest. This is Geminoid F. I had to look at this picture. On my computer, I couldn't tell what it was a picture of. It wasn't until I blew it up that I could see that the face on your left is actually a robot face. And so they're working on making robots seem more human in the way that we see in the sci-fi movies. But this isn't, of course, a sci-fi movie. This is the real thing. Geminoid F's human-like qualities have been created to help establish the etiquette of human-robot relations. How do you get along with people? That's what we're trying to teach robots. What can you say? What shouldn't you say? How do you behave? What facial motions? What physical motions? And so forth. And then it will gradually be imbued with more and more intelligence. So we will be able to interact, and it will seem much more like a human than a robot. So we have the present and the future colliding together here. We're increasingly talking to our phones, our cars, our appliances. I bought a new car this year. My wife and I are the age where we start taking money out of our IRA and spending it before it's too late. And we don't want to leave it to the kids. No way am I leaving this to Steve. We'd say, let's spend it. She says, let's get a new car. So we got a new car. And of course, we got the only car that we ever get, which is a Subaru Outback, which is the standard Wisconsin car. And, but we got a new one, and the new one has all of these audio features on it, which Bluetooth, which I had never used before and was uncomfortable. I thought, well, we won't use any of that. But it turns out that's kind of cool. You can be driving down the road and say, call home. You can say, tune the radio to WERN, or go to 94.9. And the car is doing all this stuff. Show me the map to home. Show me the map to Crowne Plaza. And it will show you these things. And I have to say, I'm getting kind of attached to that. It's awfully easy to do that. So if someone, even in my generation, can start getting used to talking instead of pushing buttons, then we all will. The computer scientists say we will evolve to love our tools, and our tools will evolve to be lovable. And that's exactly what's happening. They're getting more personal, more friendly. Will we eventually be confiding in our robots? And that's beginning to, you're probably wondering, what are you talking about? You're supposed to talk about the caregiver-client relationship, and I'm getting there. Because what I want to get to is, what's different about, why don't we just take all of our clients, put them in front of a computer screen, and say, look at these horrible things that will happen to your unborn child if you don't stop smoking and you don't stop drinking. Why don't we do that? And the reason we don't do that is because it doesn't work. And so I'm trying to get at why it doesn't work. I think it's very interesting as we will have more and more automation in our lives and in our relationships with our clients and with our patients, we're going to have to figure out what it is we don't want to lose and how we can benefit from the technology, so how it can enhance what we do. And that's what I want to argue to you today, is that your relationship with your clients is your strongest tool that you have to try to get them to do what you want them to do. And what you want them to do is what's best for them and in the best interest of their children. And that's to give up smoking, stop drinking, at least for the pregnancy, and to make a change that I think are two of the hardest things that people do. My belief is that the two hardest things that people do in their life trying to change is to stop smoking, the other is to lose weight. I think that people struggle with this for whole lifetimes. It's just so hard to do. And that's what you want the people to do. They're not going to do it if you put them in front of a computer, or even if you give them a seal that looks in their eyes and says the right things. They certainly won't do it if you hand them out information sheets, but they might do it for you if you're in a good enough relationship with them. So we're going to talk about the caregiver relationship. Why bother? What kind of relationship do you want anyway? Some tools for relating, and finally the art of listening. And then we'll be done. But I don't remember when we quit. What time did we quit? 11:30? That's good, because I could just go on. My family's always so glad when I have one of these speaking gigs, because I'm not at home in the living room with the PowerPoint set up, trying to grab someone walking by the door. Hey, could you come in? I thought you might like this video. Why bother? Woulda, coulda, shoulda. Next. Why do we bother wanting to have a relationship? Well, I've already given you some examples. I think it's probably one of the most important ways that people find motivation for change is within a relationship with somebody else. You get better diagnosis, you get better information when people trust you. The treatment is safer because you have more access to data about the treatment, and you're also more accurate with your diagnosis. You also hear more about side effects. Better treatment adherence. Treatment adherence is terribly bad. You're not necessarily interested in people taking medication, but you are interested in them showing adherence to behavioral interventions. That's what you want to do. Better outcomes and more satisfaction for you as a provider. So let's take a look at better diagnosis. When people trust you, they're more likely to tell you the truth, including the things they're really worried about. It's quite interesting. When I was in medical school, I learned from older practitioners who told me that when people come to the office to see me, if I were in primary care, or it turns out any kind of specialized care is the same, the first thing that they talk to you about is usually not the thing that they came to see you about. It's something else. And that you have to be able to keep your mouth shut for about 3 minutes in order to let them finally get around to telling you what they're worried about. I came in because I'm having trouble sleeping at night, and I have this pain in my shoulder, and I want you to do something about it. And you let them talk, and you find out they're desperately afraid that they have brain cancer. They had a friend who was diagnosed with that or something. It doesn't come out right away because they're afraid to tell you. If we talk about it, it might make it true. And so people don't want to tell you. In one primary care study, most patients who came to see a primary care doctor had 5 or more things that they were concerned about. The doctor, of course, expects one thing, right? I'm giving you 15 minutes. We'll deal with the thing that you want to deal with, and people come in and they've got a whole list because it's hard to get to the doctor. You have to take time off from work, or you have to get a ride, you have to do all this stuff. Only 11% of patients voiced everything they were worried about. And frequently it's the thing they're most worried about they don't get around to. I'm worried I have cancer. I'm worried I have dementia. I'm worried I have a sexually transmitted disease, and I'm too embarrassed or ashamed or afraid to mention it to you. Most common and voiced agendas: worries about possible diagnoses or what the future holds. Patients' ideas of what's wrong. I don't want to tell you that, I'm kind of embarrassed. Side effects of the treatment, or not wanting a prescription. This is kind of interesting for me as a prescriber. because most primary care doctors or family doctors believe that patients want a prescription when they come see them. And they think that patients will be unhappy unless I write a prescription for them, and so that's what they do. But in fact, if you talk to most people who go see a doctor, I don't want a prescription. I've got pain in my shoulder. I want you to tell me what I can do for this besides giving me a prescription. I would rather not take a pill if I have to. We talk about ourselves as a sort of pill-oriented society, but in fact, I don't know about most people. I don't have data about that. An awful lot of people don't want a pill. They want some alternative ways to deal with their problem. Treatment is safer. I medicate first and ask questions later. There's lots of information that is unknown to the treater that you need to find out about. It may be related to medical history. People don't think it's important, or they didn't remember it, or they were afraid that it would interfere with your being able to give them what they thought that they wanted. Caregivers unaware of the patient views of medicines or anxieties about treatment. Caregiver has inaccurate perception of what the patient wants. Caregivers unaware that the patient uses alternative or over-the-counter medications. And the caregiver's unaware that patients change the dose, or the patient's confused about dosage. I am astounded at how little lay people really understand about medical issues. You would think everybody would know everything about medical issues with the internet and their friends talking to them and all this information that people get handed out at health fairs and all that. But in fact, people are remarkably ignorant about that. My daughter is one of these people. I cannot believe what she thinks about the world of medicine. I'll just flesh this out a little bit with more self-disclosure, but I have 3 adopted children, and my daughter is God, am I that old? Let's just say she's older. She's in getting closer to 40 than 30. And she's African American, lives in Milwaukee, and has always lived sort of on the brink of financial catastrophe. And it's just, she chose it, and we've had long conversations about it. She says, I'm happy you're doing this. I don't want to live your life. Okay, don't live my life, but could you live something that's closer to my life than closer? Anyway, she's happy, we're happy, we all get along, we all love each other. She's chosen her path, and she lives it. But she lives in a very low-income African-American community, and I am astounded at the degree of superstition and old wives' tales and ignorance about basic medical care, from my point of view. Now, this is the allopathic, middle-class provider who goes by all of the science behind it and so forth. Now, she works she worked in a doctor's office. She doesn't do that now. She works somewhere else. So she actually, it's not unfair. I don't think that she is very ignorant about these things, but certainly the people she talks about. And the degree of suspicion against establishment medicine, at least in her community, in that African American community, is just shocking to me. I mean, it isn't if you look at the history and why, but that this persists, that people will not go to a doctor because they're afraid of terrible things that are going to happen to them. Well, we don't know that if people don't trust us, if they won't tell us what they're worried about. And no one will tell you what they're worried about unless they believe that you will not laugh at them or you will not discount what they're saying. You need to be able to say it. They need to be able to say it to you because they trust you. Patient doesn't understand, remember, agree with the diagnosis, disagrees with the attribution of side effects, and so forth. We also get better treatment adherence if people have a good relationship with us. All these years and you haven't listened to a damn thing I've said, have you? No, I haven't. Treatment adherence is important. A lot of these slides are geared toward medication, but I also intend them to include behavioral recommendations as well. When clients take their medications more consistently and are more likely to ask about side effects and are more likely to follow behavioral recommendations if they feel they're collaborating with you, not that you're just handing out recommendations and instructions to them. If they feel that they're part of the treatment plan, if you're considering their feelings and their interests and their concerns, then they're more likely to work with you rather than feel like you're doing something to them which they resist. There's a theory in social work called reactance theory that has to do with people who are in involuntary relationships. Now, this is not the clients that you're working with. This is my life, my world, where I deal with people who are committed. But once we're in a relationship where we feel that we are not participating fully voluntarily, we start to resist that. That is normal human behavior. That is not passive-aggressive. It's not antisocial. It is what you would do back when you were in high school and someone said, you can't wear that to school. You have to go to church. You have to do this. All of a sudden we go, oh yeah, we'll see. And then we develop passive-aggressive behavior. We try to get away with what we can. We resist it. We act in ways that look like we have a personality disorder. But we don't. It's the situation, and it's a normal human response. The way to mitigate that is to have people more engaged in the treatment and feel like it's their treatment and we're helping them, not we're doing this to you. So somehow we want people to collaborate with us. These are medication non-compliance rates, by the way, lest we start blaming our clients for not doing what we tell them. You will notice that non-compliance rates are all around 50%. For people who have chronic medical conditions, I don't care if it's diabetes or schizophrenia, people take their medicine about half the time. They don't take it all the time. I take it all the time. That's because I'm obsessive compulsive and scared to death of dying. But normal people don't. Normal people take their medicine about half the time. Even if you have a seizure disorder, you take your medicine about half the time. So that's normal behavior. That's the obstacle, the challenge that we face. These are things that help us get our clients to take medication and follow through with treatment plans, if it obviously helps. I never have any trouble getting people to take Valium. Why? Because Valium actually does something. It makes you feel good, and it makes you feel relaxed. I prescribe Valium, everyone takes it. No problem. I have trouble if I prescribe blood pressure medicine or antidepressants or things like that that don't obviously help right away after you take them. It's better if you just take things once a day, or you have something simple rather than complicated. Nice treatment setting, good physician communication and rapport. So this shows up on lists of why people take their meds. Subjective sense of well-being. This is interesting to me. I do a lot of teaching about happiness. What is happiness? How to be more happy. People who feel good about themselves take better care of themselves. You know, and it feeds on itself, because the better care you take of yourself, the more you feel good about yourself. So there is this circular relationship. The word I use here is self-efficacy. Do I feel like I've got control over some part of my life? And if I do, I'm more likely to act in ways that are healthy. If I feel like I've got some control over my smoking or my weight or whatever it is I'm trying to say, then I feel like I can act in a way that helps me do that. So a subjective sense of well-being related to self-efficacy, related to a sense that I have some control over my future and my fate. Social support, skill training. I mean, some people just need some help, right? How do you remember to take your pill? Well, put it somewhere where you remember where it is. And develop patterns, habits, and so forth. You can do that with drinking and with smoking. That's a lot of the prevention measures that we try to teach people. When you want to have a cigarette, here's some other things you can do. Let's practice that, and so forth. Now, for behavioral treatment adherence. A lot of the data is the same. Rather than measure how many times you take your medicine, what we measure here is how many times do people come back to psychotherapy. So they're recommended to go to psychotherapy. What's the modal? This is the most frequent number of times that people go to psychotherapy. The answer is once. Almost no one ever goes back for psychotherapy. Everyone goes once and they say, forget it, I'm not going to do that again. What improves adherence to behavioral recommendations? First impressions of the therapist as confident and competent. Why do you put certificates of your graduation on the wall? It's not to show off. Well, maybe it is for you, not for me. Norton High School, Ohio. Who cares about that? If I went to Harvard, maybe I'd do that. But actually, the reason that most people do that is to convey a sense of competence. I know what I'm talking about. Now, you need to be able to do that. You may or may not have credentials that you hang up in an office for people to see. I don't know, you may move around in your offices. I don't know how you work. But if you have something like that, show it. The way that you dress. I supervise medical students and residents. And of course, as the years have gone by, dress has changed. And people will come in and they've got all these piercings and they've got all this stuff going on. They look like, well, they don't, let's just say, if I were going to talk to somebody about my marriage problems and this person came in the room to talk to, I'd say, can I see somebody else who's like over 19 and can wear clean clothes that aren't torn? So anyway, there's just a way that I wear the uniform. I don't wear a tie now, but I do wear the blue blazer. The blue blazer is the uniform that you wear in order to convey a certain substance related to the establishment. This is established. I'm not going to take you on a wild, crazy, alternative trip. We're going to do things according to the way we understand them. And so when people come in to see you, they will be more likely to do what they say if you don't shock them by your appearance and you have some way of indicating that you've got credentials. Strong therapeutic alliance. We'll talk a lot about how to get that. Education about what we're doing. Why is this important? I'm not just making this up. Here's some things that you need to know before we get started. Contracting for homework. I don't know how this applies to what you would do, but it would sure be nice if you could. People are more engaged with therapy if we have expectations of them, rather than we just come in and say, okay, stop smoking, cut down, and I'll see you, after your baby's born. I don't know how you do that. But what homework does is it tends to engage people, and they're doing something outside of the session and they're bringing it back to you to show that they've done it. It gets people invested in the process. And then motivational interviewing techniques, which you know about. We know that better relationships lead to better outcomes. What do we know this from? Well, again, my world is the psychotherapy world. So I will tell you about psychotherapy research. In the big Kaiser Permanente system, one of the biggest healthcare networks in the world, they have looked at outcomes with psychotherapy. And what they found was that the top 25% of therapists was responsible for about 90% of their results. And the other 75% were just sort of middling, doing well. But it's the small number at the top who consistently did very, very well with outcome measures of their therapy. So that combined with other research that's been done here at UW, which shows that the outcomes of various therapies are roughly equivalent. So there are different kinds of psychotherapies. There's cognitive behavioral therapy, there's motivational interviewing, there's psychodynamic psychotherapy, there's family therapies, there's experiential therapies, there's all kinds of different therapies. It turns out that they're all equivalent. It doesn't matter what kind of therapy you do. It matters who it is that's doing it. So psychoanalytic psychotherapy is just as good as cognitive behavioral therapy if the same person's doing the different kinds of therapy. They say that roughly 5 and 9 times more important than the kind of therapy is who the therapist is. Therapy is successful about 68% of the time. The 4 common factors include client factors, so the person coming in has a lot to do with whether therapy is successful. The therapeutic relationship. Second, engagement, connection, warmth, empathy, and then expectancy, hope, placebo, and then finally the technique, which is the least important. The conclusions. Since no therapy is proven to be superior to any other therapy, it is likely that other factors rather than the kind of therapy is most important. So there are different kinds of therapies. It probably doesn't matter. Experienced therapists are most likely to do a lot of different things. Effective therapists are those who truly listen to their clients and they organize the treatment around the client's view of change. If you want the best therapy, find the best therapist. That's the bottom line about all the research about psychotherapy. Don't worry about what kind of psychotherapy it is. Find a person that your friends recommend, that people say, this person's really good. That's what's going to make a difference. It's the relationship. It's not the training and the therapy. It's not the technique. It's not the other stuff. It's the relationship. The relationship is related to the best outcome. One of the most interesting studies that I read about antidepressants and the efficacy of antidepressants was an ingenious one. What they did was they took all of the studies, and of course they're all involving different antidepressants, and they've got slightly different protocols. And what this researcher did was, instead of looking at the dosage of the medication or the brand of antidepressant, what he looked at was how frequently the research subjects were seen. In some protocols, patients were seen once a week. In some protocols, they were seen once a month. In some, they were seen every 2 weeks, and then it went to once a month. And then he looked at outcomes based on that. And what he found was that research subjects in studies looking at antidepressants who were seen more frequently got better faster. No matter what the medication being tried, no matter what the dosage, it didn't matter. It was how often you were seen. One of the things that we find when we look at studying antidepressants in older adults is that it's very difficult to study antidepressant response in older adults because everyone gets better. You can't separate placebo from active drug because everyone gets better. Why is that? Well, think about it. Here's an old man, recently widowed, depressed. His primary care doctor says, maybe you should get in this antidepressant trial. He says, no, I don't know. Okay. And so he goes to the psych department where he's met by this young, attractive, enthusiastic researcher who says, come in. Dr. Mesa, I'm so glad to see you. I'm glad you're here to participate. I just wanted to talk with you for a while, see what's going on. How's your health? How's this? How's that? Here's the medication. Here's what we're going to do, blah, 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 blah. Can you come back and see me next week? If you can't, we'll send a cab. We'll come pick you up. Okay? All right. Goes home. Week goes by. Gets dressed up a little bit for his appointment with that young therapist. And it goes in and talks about the medication. And before you know it, that depression scale is just starting to decline. The person's doing better. Why? Because so much of depression in the elderly is a problem of morale. It's not about depression. And we fix that through the relationship. So outcomes are better when we've got a good relationship with the person that we're working with. This is pretty much the same thing. If you look at outcomes by prescribers, you find that it is the prescriber that is the most important variable, not the medication, not the dosage, and so forth. It's the prescriber and how often you see them. You have been looking at ways, research, and how to get your clients to stop drinking, and you have developed interventions that are implemented by you. This is very consistent with parallel research that looks at how do we get the general population to cut down on drinking. And what we find is that this is kind of there are different kinds of alcohol. I don't want to go down here. This is a long story, but we used to think that alcoholism was alcoholism and it was all the same and it was all terrible and you ended up in rehab and you always struggled and some people got better, most people didn't. It was a lifelong battle. We now know, based on better epidemiologic data, that there are at least 4 different kinds of alcoholism, and 3 of them are time limited. People get better and they get better on their own. They cut down their drinking, they stop on their own. So we've got people who start binge drinking in their teen years and through the early 20s, and eventually they stop drinking or they get back to a more controlled drinking pattern. We have people who develop alcoholism in their mid-30s, sort of later life, and then something happens and they control their drinking. Remember George W. Bush, when he was running for president, he didn't drink, and so the press corps asked him, what is this? This isn't normal. How come you don't drink? Are you an alcoholic? He said, no, I'm not an alcoholic, but Laura said at some point, I don't like how much you're drinking. You need to cut down. He said, so I just decided to quit. He was probably in that second group where alcohol use gets out of control in sort of middle age, early middle age, but then people stop. And then there's the group that start drinking as teenagers, and they're the group that we think of as the old alcoholics. So anyway, when we look at interventions for alcoholism in the general population, what we find is that there are several different interventions, and they're all roughly equivalent. 12-step programs, medication, treatment. And what was most interesting about these studies is the brief intervention by the physician in the primary care or family doctor's office. It turns out that asking people about their alcohol use, doing a simple screening like the CAGE screen or something like that, and then having the physician say, I think that there's some evidence that you're drinking more than is good for you. Are you interested in changing that? And if the patient says, well, yes, and then the physician follows through and said, well, what's a reasonable goal for you? And that person, well, maybe instead of drinking 3 6-packs every night, I could cut down to 1. And the doctor says, okay, let's try that. Will you call me next week? Or I'll call you. We'll see how it's going. Okay, very simple, 15 minutes. Algorithms described here at this particular website. It turns out that brief intervention by an untrained professional is as effective as people who are trained drug and alcohol counselors who go through all these big rigmaroles of treatment and inpatient stays and all that. Now, not for everybody, but for some people. What you need to understand is that certain interventions work for some people, other interventions don't. So when I say they're all roughly equivalent, I don't mean that they're all roughly equivalent for the same person. I mean in a population. Some people are going to do better with this intervention, some with this. But it is so interesting to me that a practitioner who's seeing somebody, not a trained substance abuse counselor, can have as big an impact on people controlling their substance abuse as all of this other fancy stuff in the system. And that's you. One thing that's important is the placebo effect as well. I know that you're not prescribing. This is Hiram Dodson, member of Placebo Group. Didn't work out for this person. But not that you're prescribing placebos, but rather that the placebo effect is based to a large extent on the relationship between the prescriber and the person taking the placebo. And what we know about that is that placebos have an important role in all of medical treatment. A lot of our response to any medication or chemical that we take is an emotional response, and our mind does heal our bodies. We just don't understand how that works. It's not magic, it's just not understood yet. So that's an important thing. But what enhances the placebo effect is what I want to get here. It's the relationship. What kind of relationship do you have? Are you dealing with a recognized healer who has healing symbols? One of the things I'm pointing to here for you is you will have a better impact on your clients if they have confidence in you and they see you as competent. I'm not asking you to do things that will alienate you from the group that you're working with, to make them feel stupid. That's not going to help. You don't want people coming in and saying, okay, you're going to do what I tell you to do because I'm so much smarter than you are and I'm so much more educated. That's not going to work. But it's also not going to work if they come in and they see you as a peer. You're just like them. No, you're not just like them. You're in this position because you know something and you do something and you're successful and good at what you do. And that, even though you don't feel that, you need to act that way. You can rely on me. And then the next step, after you have conveyed a sense of competence, is you can rely on me. Now I want to hear your story. Because it's not about, here's the trap that you'll fall into. If you get into trying to set yourself up as an expert, the trap is, well, experts convey their wisdom to everybody. And that's what you need to not do. It is not about what you have to say. It's about what they have to say to you. And I don't know how to convince you of that, other than I'll say it about 50 times today. But it's the absolute truth. I have the hardest time with my young doctors doing this. It's not what you know when you go in the room. It's what you hear from the patient. That's when people are going to change. If they talk, not you talking. You can talk to your blue in the face. In fact, if it was what you said, if I were up here and I just wanted to train you what to say, we'd skip you and we'd just do the computer. Or we get one of those sociable robots. But it's not about you. It's not about what you have to say. It's whether people will talk to you. And you want to convey competence and confidence, not so people will listen to you, so people will talk to you. That's what you want. And that's the way to help people change. So, recognized healer, healing symbols, healing rituals, people like that. People want to have a diagnosis. They want to know what's wrong. One of the things that I always tell people, I want to get people to exercise. I want them to lose weight. I want them to stop smoking. Write a prescription for that. People love to have prescriptions written. Walk around the block twice a day. Sign it and hand it to them. It's good. People like it. Strong placebo effect. This is more inspiring confidence. Look professional. Display symbols of healing. Make notes. Take time. Ask questions. And elicit the patient's beliefs. Offer optimistic prognosis. Use a prescription pad. Everyone can get a prescription pad. Just go to Kinko's. They'll print one out for you. We also know that if you have better relationships with your clients, you're going to have less burnout. Burnout is a problem with those of us in health professionals who are working with clients who are not necessarily very compliant. One of the symptoms of burnout is we all wish we were doing something else. And so I certainly wish that for a great proportion of my career. I wish that I had been an ophthalmologist, because being an ophthalmologist seems like it would be so calm, because you work in rooms that are dark and you sit in front of this machine and you go A or B, 1 or 2. And I could do that. I could do that all day. And then I'd see a patient, then I'd go take a break. And I'd breathe, listen to some music. And then I'd go do another person, A or B. And I could spend my life like that. I would have been so different. But anyway, burnout. Burnout is a process where burnout is not just being tired. Burnout is being exhausted. Burnout is feeling cynical. And burnout is a feeling that I'm not accomplishing anything. When you get these three things together, you end up feeling burnt out. And burnout is a problem, In terms of your physical health, it's also a problem for the organization, because employees who are burnout are not very effective employees. They don't do very well. Burnout arises from many different things, but it often arises from a mismatch of 6 different parameters. People have looked at this and they said there's really 6 things that we look at in the workplace. And if you're not a good match with what your expectations, what the expectations are of you in a particular setting and what you feel that you can offer, then that can create an internal stress and lead to burnout. The mismatches that arise are in terms of workload, control, reward, community fairness, and values. So workload. Obviously, we all have different energy capacities. Some of us are very energetic. We can work 10, 12 hours a day and come home and take care of 17 children, and they're all under 2. And I see people like this. It just makes me nuts. My wife and I we're at the national park age. So we love to go to national park. I don't know what it is. Something kicks in. It's just like, I go to national parks and I buy cars based on safety features. Something happens. Anyway, it's happened to her, not me. She's sort of pulling me along. It happened to me too. So we go to national parks. And there at the national parks, we inevitably see these mothers with 3 kids, like 2 of them are in strollers, and one's hooked to the back of Dad, and she's carrying all this stuff through the airport, and they're going camping, in Glacier National Park in a tent, and they head off into the woods. I can barely walk from my room to the dining room in the morning because I'm so stiff, and I think, how do people have the energy for that? Well, some people do, and it has a lot to do with how young you are and so forth. We all have different energy levels. I had a doctor at Mendota who was very, very energetic, and he was so energetic, if I didn't keep him busy, he'd get into mischief. And he would start doing things he shouldn't do, and running groups with patients that shouldn't be together and doing all this. And so I had to make sure that he had twice as much work as anyone else. And he would sort of comment about that and complain. I say, yeah, but you're the only person that can really do this. And he would say, okay. And he'd be much happier. He'd just be happy, just twice as much as anybody else. So your work setting has a certain expectation with how much you can work. If you don't match that, that can be a source of stress for you and your employer. It's either you want to do more or you want to do less. And work is especially draining when it requires you to display emotions that are inconsistent with how you feel. If you're having to be nice or respectful to people that you don't like, or if you're having to take verbal abuse from people and you don't want to do that, this is draining. This is really, really tough. So you have to be aware of that and try to pay attention, because if that's the problem, then maybe there's something that can be done about it, maybe not. Another area of mismatch would be control. Some of us want to be in control. Some of us like having power. Some of us don't. At Mendota, we had line staff, we called them, but they were nurses' aides, basically people with high school education, no other training than that. And they would be working on the units with the mentally ill clients, patients. And sometimes one of them would just show so much skill in being able to interact with other people. And I would talk to them and say, I really appreciate what a good job you did with so-and-so today. And it isn't just that, but I see you do it a lot. Have you ever thought about going to school? I think you'd be a great nurse or doctor if you wanted, or social worker or someone. I think you are really good with people. Only to have them say, no, I don't want to do what you do. I don't want to do what they do. I want to go home at 2:30. I want to come in at 7:30. I want to go home at 2:30. I don't want to think about anything in between. So they didn't want that degree of responsibility. On the other hand, if I look back at my life, apparently I do, because I sought out jobs that were always in emergency care or dealing with the most violent crisis situations. That's what I've sort of chosen. So I guess I like being called and being said, there's an emergency, everything's falling apart, what should we do? I like doing that. So it was a good match for me, but my job wouldn't be a good match for lots of people, so you need to know about that. You also may feel that your responsibility exceeds your authority. That's very common. We feel that we're sort of responsible for these outcomes, but we don't really have the power to make them happen. We can't fire the people who are being bad. We can't make the clients do what we need them to do. We can't change the healthcare system in the state of Wisconsin, yet we're expected to make it work. And that can be very frustrating, for some of us more than others. Reward. Now, a financial reward. Any of you who went into this with the idea of getting rich, I'd like to see you during the break when we get done, because we need to talk a little bit about your future wealth in working in social services. Those of us who want to get very, very rich, I'm hoping went into finances or banking or investments or something like that in college, not taking care of people who don't have any money. But that's okay, because while all of us sort of clench our teeth when we read about another $500 million bonus for somebody in Wall Street, we think, God dang it, I wish I had just $100 million. In fact, most of us don't put money up at the top of our list of things that we want. In fact, money doesn't come really close to the top 5 things that we want, which is fine. That's the way people are. But we do want to have some kind of reward for what we do. Money is one way to acknowledge that you do a good job, that you're appreciated. But you also get that from verbal statements from supervisors or other sorts of feedback from somebody. Now, in my work, I didn't get that from patients, since they were all involuntary and ordered by the court and mad at me and wanted to kill me. But I did get it from supervisors. I did get it from an inherent sense of what I was doing was worthwhile, and I was working with a population that I thought needed good care. It's interesting, in mental health, the best psychiatrists tended to work with the least sick people. They'd sort of set up these fancy therapy practices in Beverly Hills and do that. In other medical specialties, the best always worked with the sickest, but not in mental health. So I thought, well, I mean, not that I'm the best, but I thought I was pretty good. And anyway, I thought, well, I'm going to work with the sickest too. So that's what I did. So I get satisfaction out of that. But I need satisfaction from somewhere, because if you don't get it, you're not going to be able to continue doing it. I reviewed your salary as you requested. We're paying you too much. You have to be careful in asking for what you want. You might not get it, but anyway. You can lose a sense of positive connections with others at work. A lot of us want that. I didn't know this, but I found out that I enjoyed working as a mental health team rather than as an individual practitioner. I thought I would want to be an individual practitioner, and I chose a mental health group where I would just be doing therapy, but I chose it because I really liked the people, but I never saw them. I'd go to work, say hello in the morning, but then I'd be seeing clients all day in my office, and then everyone would have gone home at night, so I wasn't really working with anyone. I like working with a team better, and that's why I went into public psychiatry rather than private psychiatry. Some of you may not feel that way, but we tend to value our contacts with people that we work with, and if you're not getting enough of that, you might look at ways in which that can be increased for you that would help your morale. By the way, the most destructive thing is chronic unresolved conflict at work. Have you ever worked in a situation where there were 2 people who were fighting or who just sort of hated each other? It's awful, awful, and doesn't get resolved. That's a supervisor's responsibility. You've got to take care of that. You've got to fix that. Something's got to give, because people cannot work in a toxic atmosphere like that. The other thing is fairness. Fairness is most predictive of future burnout. If people feel like this workplace is unfair, we are born with an intuitive sense of fairness. Any of you who've had more than one child in the house know that as early as 1.5 or 2 years old, they are pointing and saying, you got 5 jelly beans in your Easter basket and I only got 4. That's not fair. And there's a sense of fairness, like life should be fair. We need to make it fair. Well, we feel the same. We keep it forever. We don't lose that. And we try to get over it because life isn't fair. But at work, life should be fair. And we want people to have the same compensation for the same degree of work. We want to understand it. We hate it. This is why inter-office affairs are so toxic, because there's this feeling that if you're having an affair with your supervisor, you're going to get better assignments, you're going to get more money, you're going to get something like that. It's not going to be fair. And people will quit a job like that if they feel like it's not fair here. And that's one of the things that is predictive of burnout. And then values. We want to feel that we are in a situation where we act ethically. And that is, I hope in all of the settings you work, it's true. There are certainly temptations in agencies to bill in ways that are pushing the envelope of what's honest and what isn't. If you have problems with that, it's going to increase your risk of burnout. Here, you want to be plant manager, take care of this. One of the things that I encourage you to do, if you feel like some of these areas are areas of conflict with the expectations of you and what you feel you can do, is to describe the problem in terms of that. It's not helpful for me as a supervisor if you come to me and say, I'm burnt out, something needs to change. It's more helpful if you come to me and say, I feel like the degree of authority that or the degree of responsibility you're giving me isn't consistent with my authority. And so I'm feeling this pull, I'm torn, and it's really interfering with my work. Can we fix that? Or can we fix my workload? Or can we make this a little bit more supportive? Or I need some more support, something like that. If you can identify an issue and one of those 6 is a good place to start, it will help. Now, my main point here for today is having good relationships with the people that we take care of is a strong protector against burnout, of feeling efficacious, like I'm doing something, like this is meaningful, and I'm getting something for what I do. If you're not in a relationship with someone, I know if I were an ophthalmologist and I were just going A or B, 1 or 2, I probably wouldn't have a good relationship with my patients because I wouldn't see them except behind this thing. Maybe that would be okay, though, if it were just really calm. Maybe I wouldn't need it. Maybe I could have a relationship with my incense and my music and my water feature in my office. You can tell I'm just having some problems with working with involuntary clients screaming at me all day. Anyway, you know what I said. Relationships matter. Now, what kind of relationship? What time are we quitting? 11:30? 11:30?
Yeah, 15 minutes.
Okay, all right. See, I get going. And that's you need to, people would walk out and eventually I would get it. But it might take a while before I got it. What kind of relationship do we want? Well, what is a good treatment relationship? It's more than being nice. It's not just standing there and being really happy and supportive and whatever the person tells you, you agree and you nod your head and smile and give them coffee and cookies and all that kind of stuff. Having a good relationship with someone when you are a treater and they are receiving your care involves respect, and it also involves honesty. So you need to develop ways of being honest with people. I mean, it's not just helping people feel good about themselves. Quite honestly, some people need to not feel so good about themselves. They need to change. They need to be different. And you need to be the person that can tell them that, but you need to do that in a way that doesn't alienate them. I want you to think for a second. Do you have a relationship with somebody? This is so rare. I could think maybe only 1 or 2 people in my life who someone could be so honest with me, but it was okay. I could just hear it, and I didn't feel like it was personal in a way. And this person I just knew they were going to say stuff, and they would be they'd make me angry, they'd disagree with me, whatever, and it was just okay. They had a way of doing that. That's always what I aspired to. I want to be able to tell you what I think, but have you listen and not take it personally, not get defensive, and not sort of argue back. So having a good relationship is that. It's more than being nice. It's being able to listen non-judgmentally. You need to be able to not, it is so easy to judge other people's lives because other people are making such a mess of their lives. But we don't really understand all of the things that have gone in for the decisions that they've made. One of the things that I have learned in studying the brain all these years is how complicated it is, how little actual control we have over who we are and how we behave and how we respond. It takes enormous effort to break free of all of our old patterns. It's very, very difficult to change. And I'm not surprised that everyone hasn't done that. Also, judgment implies that you know what's best for everybody. And that's a little bit hard to give up. This idea that we know how you should choose, what you should do. And I think that in general, most of us, as we get older, we become a little less certain that we have all the answers for everybody else. It's being warm and supportive. Nobody's going to talk to you if they don't feel like you like them and you respect them. It's being credible, being seen as an expert. It's being trustworthy and consistent, and it involves good boundaries. One of my fears when I talk to a group of people like you is that all of a sudden you're going to have bad boundaries now. And you're going to be all warm and supportive and gooey and lovey-dovey, and you're going to end up getting into relationships that you don't want to be in ways that you don't want to be in it. All of our relationships have boundaries. Our relationships with our significant others, our relationships with our children, our relationship with friends, supervisors, people we know on the street, and your relationship with your clients. They all have boundaries, and all of these boundaries are different. It's important, though, that the boundaries that you have with your clients are clear and you don't cross them in destructive ways. Now, boundaries change. Over time, boundaries change a lot. We have, in my generation, I grew up in a small town in Ohio where nobody talked about anything, even in the family. Right? I didn't know how much money my parents made. I didn't know how much money our house cost. My father would have illnesses. I never knew about it, never told me, let alone tell everybody on the block, you know, what your house is worth and how much money you make, or put your colonoscopy up on your Facebook page for people to see. This is very, very different than the world that used to be. So people are sharing more and they expect more. Your clients are going to expect more of a personal relationship with you than they would have 15 years ago, right? We don't even call them patients anymore. They're consumers. A consumer has a right to know all about the person providing their service because they're buying it. So there's a change here with boundaries, and you need to be careful that you don't fall into boundary problems, which would be in the realm of what I would talk about as a boundary violation. And boundary violations happen when you're no longer acting in the interest of your client, but you're acting in your interest. You find it rewarding that this person likes you, or maybe you want to be friends with this person, or maybe there's some sort of other benefit that you're getting from it. But anyway, something's clouding your thinking. So it's not about the client, it's about you and your relationship with them. Now, one way that this happens is through self-disclosure. I'm aware that I've only got about 10 minutes and I'm going to have other things I want to talk about, but I'm coming back this afternoon. So I want to talk about some of the rest of this. For those of you who are just gnashing your teeth and pulling your hair that I'm not going to go get over all of the stuff, relax. This afternoon I'll be back. So I'm just saying that so that we can calm down and not be too upset. But I do want, because I want to spend some time on self-disclosure. Because a lot of people use self-disclosure as a way to sort of push, turbocharge rapport. They think if I tell you about myself, then you're going to trust me more, right? The person's going through divorce that you're seeing. They're so upset. And then you say, I know how you feel. I went through a divorce myself. Self-disclosure, it's done in the interest of deepening the rapport with the client. But my experience is that it almost always backfires. Because, number one, your experience is not your client's experience. Even though you say it is, they will say, no, it's not. You don't know how I feel. Because my life is different than yours. So there's that. Secondly, I think it has an off-putting effect on clients in they stop talking. Because you've said, I understand what you mean. I'm going to base it on my experience. And you cut them off. You're not going to give them a chance to talk about how they feel. So my recommendation to people is don't self-disclose. I think that that's a little bit too rigid. I think that there may be times when some self-disclosure does make it more possible for you to collaborate with somebody rather than for them to see you as some sort of expert who's aloof. But you need to be careful. First and foremost, are you acting for the benefit of the client, not just talking to them about things about you that you want to share with somebody else from your personal life? Is the self-disclosure clinically driven? Is it having an impact on the client? And finally, ultimately, are we fostering autonomy in the clients that we work with, which is an important part. Tools for building a useful relationship. And what I want to talk about here is developing rapport, and I want to talk about listening skills. But I think what I'm going to do is just stop here. We will talk about some of this afternoon and give you a chance, if you'd like to say anything before we take our break, have any questions or comments, we can do that. But we'll also have a lot of time for that this afternoon as well, if I decide to come back. I probably will. I'm feeling positive, but you never know what could happen. Anything you want to ask about or talk about? This makes sense to you? Is it relevant enough? Okay, well then you get out of this session 5 minutes early, and I will be back this afternoon, and I'm going to talk then primarily all about rapport and listening. We're just going to talk about some techniques for doing that and how to make it go a little bit more naturally. Roar of applause.